Thank you, Damien, for the introduction. The treatment of pincer deformities aims to remove the pathologic acetabular cover, and there are several techniques which you can do that. So one would, if you have a severe acetabular retroversion, as we have seen this morning, you may choose an antiverting PAO. If you have focal overcoverage, then the solution may be open or arthroscopic rim resection with reattachment of the labrum. If you have global acetabular overcoverage, the optimal treatment would, at least in the opinion of open surgeon, is by surgical dislocation, but this is always debated on the meetings. But arthroscopically, you certainly have technical difficulties to resect the acetabular rim circumferentially at a correct level. So we did a retrospective study on our own patients where we reviewed the correction potential of arthroscopic and open surgery for pincer deformations. And we evaluated if surgical hip dislocation provides a benefit over hip arthroscopy regarding the power in the treatment of correction. So we looked at a number of patients from the area when I started in Lucerne from 2008 to 11, and there were 226 hips that were treated for impingement. We had to exclude some for previous surgery, incomplete documentation. So we were left with 85 hips in 82 patients. 44 were male, and the mean age was 35 years. We looked at the usual radiographic parameters, the lateral center edge angle, the acetabular index, and the alpha angle measured on the lateral cross-table view, following the technique of Nötzli. And we did some statistics on those, ANOVA for comparison between groups and regression analysis. The groups were, we have much less surgical hip dislocations than hip arthroscopy, so it was probably the half number of surgical dislocations. We had much more males that underwent the surgical hip dislocation. There were 80% males. Hip arthroscopy was 37% males. And the mean age between those groups was quite similar, 43 years, plus minus 10 or 12. And quite balanced left-right hips. So if you look in there are two columns, the surgical hip dislocation group and the hip arthroscopy group. So we had 7 hips in the dislocation group that had a pure cam or only a cam, and 22 that had a mixed or a pincer deformity. In the hip arthroscopy, we had more cam deformities, but still a little bit more mixed pincer and pincer deformities. If you look at the LCE angle on those two groups, in the open group, it was significantly higher than in the arthroscopic group, and that was the same accounts for the acetabular index and in both groups, and the alpha angle was also larger in the open group in this series. So there was a significant difference between the lateral center edge angle and also in the alpha angle. We looked at the post-operative measurements, and what we found that we equally well corrected the lateral center edge angle to about 26 degrees in both groups on average. Also, the acetabular index was corrected to about 7 degrees. Those differences in those two measurements was not significant. We had a difference in the alpha angle, which we had a bit more correction in the hip arthroscopy group, and this difference was significant. Clinically, we also looked at the Harris hip score and the Oxford hip score at 2 years. We didn't have any significant difference between the Oxford hip score and the Harris hip score for patients treated open by a surgical hip dislocation or a hip arthroscopy, so the results were absolutely equal. Now, surgical dislocation and hip arthroscopy both can be used to restore the main radiographic parameters to normal values on the acetabular side. In this cohort, of patients, the surgical hip dislocation was used to treat more severe pincer deformities. So we changed our analysis a bit around. So we looked, we divided those groups into hips that had a high correction and into a normal correction. Now, what's a high correction? We defined the high correction to be larger than 2 standard deviations from the mean in a population with acetabular overcoverage. And the same for the acetabular index, which means if you make the calculation, if you have an LCE correction of more than 12 degrees or an acetabular index correction of more than 8 degrees, that was classified as into a high correction group. So if you now compare these two groups, you'll find that, again, the age is pretty similar. Now, the gender distribution is different. We have equally male and female patients in the normal correction groups and a little bit more male per age patients in the high correction group. And if you look at the percentage of hip arthroscopies, the normal correction groups were more treated with hip arthroscopy, but there's still about 1/3 to 2/5 that were treated also arthroscopically had an arthroscopic high correction. If you look at the results, the pre-op results, there's a significant difference, of course. So the pre-op LE in red was 40 in the normal group, and 30 in the normal group, and 40 in the high correction group. And the difference of correction, of course, we know that from the previous data, was much more extensive in the high correction group. And this is also reflected in this graph, which shows that the overall acetabular correction, incorporating both acetabular index and LCE, was 10 degrees in patients undergoing hip arthroscopy and 22 degrees in hips undergoing surgical hip dislocation. We did then linear regression, showed there is no difference in the correction between surgical hip dislocation and hip arthroscopy, provided the correction was in the normal group. And surgical hip dislocation demonstrated a pronounced effect on achieving a high correction of acetabular coverage. And the odds is about 10 in favor of surgical dislocation. There was no difference with regard to the femoral head neck junction correction, so the alpha angle was not influenced by either technique. So the surgical hip dislocation proved to be much more powerful to obtain acetabular correction. However, there's, of course, limitations. It's a single surgeon series, and it reflects part of the treatment algorithm. Still, there are some high corrections done arthroscopically, but in general, when we see a deep acetabulum, for us, especially if it's circumferentially deep, then we still favor an open procedure. Luckily, we have some algorithm which really works because it can be demonstrated in a formula shown below. And if you use this formula, you can predict to 95% how you will treat it and how you will obtain the correction. One limitation is also we only measured the lateral central edge angle and the acetabular index, and we know that these two measures just showed where the lateral point of the acetabulum is. So we don't know, we didn't measure, we didn't perform an analysis on what happens to the anterior cover or posterior cover. That's certainly a limitation. But overall, the study shows that good correction can be achieved, provided the technique has to be tailored to the hip pathology. Thank you very much for your attention.